This is the first meta-analysis to evaluate placebo-controlled randomized controlled trials that compared the effects of acute exercise interventions to control groups in healthy adults on statin therapy. Self-reported SAMs tended to be 5% greater after acute exercise in statin users compared to placebo. Our data provide a promising direction for reducing apprehension towards physical activity among statin users. Yet above all, the methodological limitations we outline should encourage future investigators to conduct well-designed, rigorous, more long-term exercise training interventions. Hi, my name is Laura Mangone. I'm a PhD candidate at the University of Connecticut in the Department of Kinesiology Human Performance Laboratory. On behalf of my co-authors, Drs. Oh-Sung Kwon, Blair Johnson, Yin Wu, and Linda Pescatello, it is my pleasure to walk you through our original research article entitled The Role of Exercise in Statin-Associated Muscle Symptoms Outcomes, a systematic review and meta-analysis of randomized controlled trials. This study will appear in the April issue of Mayo Clinic Proceedings, Innovations, Quality, and Outcomes. Statins are the most commonly prescribed class of pharmaceuticals to treat elevated LDL cholesterol and thus the primary and secondary prevention of cardiovascular disease. Discontinuation and non-adherence to statin therapy persists despite the drug's effectiveness in lowering LDL cholesterol. Statin-associated muscle symptoms, known as SAMs, are a major reason for statin discontinuation. The negative press coverage that statins receive could not only lead to reduced medication compliance, but reduced physical activity. Either consequence is worrisome, given each therapy's independent ability to lower mortality risk and their combined ability to lower mortality risk that is greater than either therapy alone. We systematically searched 5 electronic databases for placebo-controlled, randomized controlled trials through January 2023. We included acute and chronic exercise interventions that compared the efficacy and safety of exercise plus statin versus exercise plus placebo in healthy adults and reported SAMs pre- and post-intervention. Surprisingly, only 5 acute exercise interventions emerged from our systematic search of the literature. Consistent with findings from other double-blinded, randomized controlled trials, our meta-analysis showed that self-reported SAMs tended to be 5% greater after acute exercise in statin users compared to placebo, although this difference did not achieve statistical significance. Exercise-induced creatine kinase and aerobic capacity, as assessed by VO2 max, were not significantly different in statin users compared to placebo. Further, exercise and statin combined therapy markedly improved LDL cholesterol compared with exercise and placebo. The small risks of muscle symptoms compared to the many cardiovascular benefits of statin therapy and physical activity call into question the exaggerated claims about side effect rates with statin therapy. This slight increase in the risk of SAMs with exercise should not be a reason for patients who exercise regularly to discontinue exercise or statin therapy without being evaluated by their physician, especially given the well-documented benefits of regular exercise on cardiovascular and all-cause mortality. Our article highlights the important need for placebo-controlled randomized controlled trials investigating the prevalence of statin-induced SAMs during more long-term exercise training programs.